let's get started. Hello, everybody, and welcome to another MOGcast entitled Overlaps and Differences Between MOGAD, MS, and NMOSD. So today we are speaking with Professor Fabienne Brilot, Professor Russell Dale, and Associate Professor Sudarshini Ramanathan from the Kids Neuroscience Center and University of Sydney in Sydney, Australia. My name is Julia Leffler, Executive Director and co-founder of the MOG Project. The MOG Project is a US-based nonprofit organization devoted to raising awareness, advancing research, and providing support and advocacy for the MOGAD community in hopes of finding a cure. We would like to thank the doctors and the MOG Squad for their contributions to this MOGcast. I'm co-moderating this MOGcast with Jenny Kazan. Jenny?
Thank you, Julia. My name is Jenny Kazan, and I'm the Australian Ambassador and Medical Professional Outreach Specialist for the MOG Project and a primary school teacher in Western Sydney, Australia. I was diagnosed with relapsing MOGAD in March 2020 after a prolonged history of recurrent optic neuritis. This MOGcast is being recorded and will be available on our website, Facebook page, and YouTube channel. If you want to submit questions, please feel free to do so by commenting on this chat or Facebook Live video.
So we're going to be answering community questions, time permitting. So any of the other questions that are unanswered are going to be answered on our follow-up MOG blog or a future podcast. So please stay tuned for anything you put in the chat. Jenny?
I'm delighted to introduce Professor Fabienne Brilot, who obtained her PhD in Belgium and at the J.D. Gladstone Institute, UCSF, USA. She then became a postdoctoral fellow under the mentorship of Professor Christian Munz, University of Zurich, Switzerland, at the Brown Center for Immunology and Immune Diseases, headed by late Professor Ralph Steinman, Nobel Prize for Medicine 2011 at the Rockefeller University, USA. She was recruited at the Children's Hospital at Westmead in Sydney in 2007, where she started the Brain Autoimmunity Group. Fabienne is Principal Research Fellow at the University of Sydney, and her research focuses on neuroimmunological brain disorders, such as demyelinating disorders, movement, and psychiatric disorders. Her group aims to discover biomarkers and explores the autoimmune response in patients to improve their diagnosis and treatment. Through many collaborations with pediatric and adult neurologists, her team has contributed to the characterizations of MOG antibodies in the diagnosis of MOGAD. Fabienne is a member of the International Society of Neuroimmunology International Advisory Board. She is the Secretary of the International Women in Multiple Sclerosis Network. She's also the President of Neuroimmunology Australia, was the Scientific Chair of the 14th International Congress of Neuroimmunology 2018, and was the co-convener of the 3rd Asia Pacific School of Neuroimmunology in 2023.
Yeah, thank you. So I'm excited to have here with us Professor Russell Dale, who is a professor of pediatric neurology at the Children's Hospital at Westmead and University of Sydney. His primary interests are in autoimmune neurology and the role of the immune system in neurodevelopmental and neuropsychiatric disorders. He's head of school and head of the specialty of child and adolescent health at the university and clinical director of the Kids Neuroscience Center, a research center of 100 researchers. He has published 330 peer-reviewed publications, cited 25,000 times on Google Scholar, H-Factor 81, and has published some important work on the clinical and radiological phenotyping and treatment of autoimmune and inflammatory neurological disorders. He works closely with Associate Professors Sudarshini Ramanathan and Professor Fabienne Brilot, and autoantibody neurology syndromes in Sydney, including MOGAD.
We're also thrilled to have here with us Associate Professor Sudarshini Ramanathan, who was a neurologist and clinician scientist with subspecialty expertise in neuroimmunology. She is a staff specialist neurologist at Concord Hospital in Sydney, where she looks after patients with autoimmune neurological disorders. She leads the Translational Neuroimmunology Group at the University of Sydney. Her clinical and fundamental science research program is focused on understanding disease pathogenesis and improving the diagnosis and treatment of autoimmune neurological disorders including MOGAD, neuromyelitis optica spectrum disorder, autoimmune encephalitis, autoimmune muscle disease, and inflammatory neuropathies. In 2013, Associate Professor Ramanathan established and has since been the lead investigator of the Australasian MOGAD study group, which encompasses over 150 neurologists, immunologists, and ophthalmologists from over 45 centres in Australasia. She works closely with Professor Russell Dale and Professor Fabienne Brilot to evaluate a cohort of 700 MOG-positive patients. We are here today to talk about one of the most extremely hot topics in neuroimmunology, overlaps and differences between MOGAD, MS, and NMOSD, which has a lot of questions and answers that we're ready to explore here in this podcast with our Australian experts.
Yeah, so I just wanted to welcome everybody, and we're really excited to be, highlighting the work that you do in Australia. So let's get started, everybody. Jenny, you go first.
We would like to begin this podcast by exploring some of the similarities that MOG antibody disease, multiple sclerosis, and neuromyelitis optica spectrum disorders have in common. How do these three demyelinating conditions, MOGAD, MS, and NMOSD, present similarly to each other in a way that might confuse some physicians when investigating our diagnosis for one of these disorders? Professor Fabienne, if you would like to start us off by answering this question.
So thank you, Jenny and Julia. I'm very happy to be here. I think it's due that at first presentation, the patients can have the same type of phenotype. So we know, for example, that the three diseases can present as an optic neuritis, which is an inflammation of the optic nerve. And so that makes it difficult, I think, for physicians to really see a difference when patients present with similar symptoms. Now, we know that pathogenically, they don't behave the same way. There's different antibodies. There's probably a different role of T cell in the immune system. But at first look, many patients will present with an optic neuritis in MOGAD and in MS, and that's going to be at the first presentation. They will evolve and the disease will become clearer with time and relapses. But some patients will also present with a transverse myelitis, which is a demyelination in the cord, and also some lesions in the brain. So overall, on first examination, it is indeed confusing because of this overlap of clinical phenotypes between the three diseases.
Julia, you've muted yourself.
I apologize. Thank you. So I was saying, what are some similarities and potential triggers in these three disorders that might activate an immune response leading to a particular presentation? Are there any differences in triggers for relapses for these diseases? And I'd like to ask that to Dr. Darshi.
Hi, Julia. So it's long been accepted that there are certain triggers for some of these immune-mediated conditions. So, for example, infections are one of the most well-established triggers. It's not uncommon for a viral infection to occur a week or two before an antibody-associated neurological condition, such as MOGAD, NMOSD, potentially, autoimmune encephalitis. And it's not necessarily always the same infection, so it can occur due to a number of infections, frequently viral. And the thought behind that is maybe with systemic inflammation, there is some loss of integrity of structures that are quite good in health, like the blood-brain barrier. So that circulating autoantibodies, such as that which target MOG in the peripheral circulation, might be able to target the central nervous system instead. So infection can certainly be a trigger, and infectious triggers in MOGAD have been identified in about 40 to 50% of patients. And this is probably a higher percentage than you would see in, for example, NMOSD or MS. Other triggers have been in autoimmune neurological conditions. They sometimes document a preceding vaccination, for example. However, this has never been proven to be causative in larger population studies, and the broader public health benefits of vaccination mean that we wouldn't recommend any changes to established vaccination schedules. I suppose triggers should also be differentiating a genuine relapse from a transient worsening of symptoms. And it's well established in multiple sclerosis, for example, that heat or exercise can sometimes cause a transient recurrence of symptoms from a previous episode. And this is referred to as Yukhov's phenomenon. But this is reversible when patients cool down, and it's not thought to represent a genuine relapse. So I think the most clear trigger in the literature to this point is probably infectious causes. Thanks.
Thank you, Associate Professor Ramanathan, for that excellent response. I would like to move on to presentations and symptoms at onset in comparison to pediatric and adult patients. What are some differences in presentations and symptoms that the physician might see in the clinic when trying to determine a MOGAD, MS, or NMOSD diagnosis in a child? Professor Russell-Dale, if you can kindly answer this question from a pediatric perspective, and then Associate Professor Ramanathan from an adult perspective.
Thank you. So hi, everybody. So as Fabienne started, all of these disorders are central nervous system demyelinating disorders. So it affects inflammatory demyelination of either the brain or the optic nerve or the spinal cord. And depending on where the problem is, will influence the symptom, be it blindness or paralysis or drowsiness. I think the main difference between kids and adults is the presence of ADEM, which is an acute encephalopathy, inflammatory encephalitis, and it's strongly associated with MOG disease. So about 60% of children presenting with ADEM, and these children present with drowsiness, behavioral change, and sometimes they require intensive care. About 60% will be MOG antibody positive, whereas ADEM is far less common in adults, relatively uncommon presentation. So that is the main difference between children and adults. Otherwise, there's more similarities than differences. So MS in adolescents looks similar to MS in adults, although it tends to be a bit more of an inflammatory disease, a bit more relapse rate and more inflammation on brain scans. And then the other difference that is very helpful in optic neuritis is whether it is unilateral, meaning one eye, or bilateral, meaning both eyes. That can be helpful to separate these disorders. And we see quite a lot of bilateral optic neuritis in children. And we also see what we call transverse myelitis. That's when the whole of the cord is inflamed and it results in paralysis of either both legs or sometimes all four limbs. So that is the sort of the main difference between kids and adults. Darshi, anything to add?
Thanks, Russ. I suppose the other aspect of the question is what helps differentiate the conditions from each other. And I think Russell's already pointed out the main difference between children and adults. And I think the other clinical presentations that might add some light on the possible diagnosis is, as Russell mentioned, the bilaterality of the optic neuritis, which is frequently seen in MOGAD and also NMOSD. To a slightly lesser degree is vanishingly rare in multiple sclerosis. So if you get that bilateral optic neuritis, you'd be thinking about an antibody-mediated demyelinating condition. I think an interesting differentiation between the conditions is also having brain involvement with seizures, which is something that we do see in just under 10% of MOGAD patients. And you don't really see that when you have brain lesions in multiple sclerosis and in NMOSD. That association with seizures is very unusual, whereas it's a clearly documented and recognized phenotype in MOGAD. And I suppose the last point I'd make to differentiate between the three conditions is very dominant involvement of the lower part of the spinal cord which is called a conus, that results in bladder and bowel dysfunction, can certainly occur in all three conditions, but it occurs at a higher rate in MOGAD than in MS and in NMOSD. So those are the only three additional things I would add.
Okay, thank you. So you started to kind of talk about lesions in certain areas, but we want to get a little bit deeper and just possibly could you talk about the radiological differences between these three disorders that might help physicians make a MOGAD or MS or NMOSD diagnosis if that's what they're looking at? And if so, could you kind of describe what they are? Dr. Darshi?
Sure. So as we've already established, involving the optic nerve, the spinal cord, and the brain is a common feature of these three conditions. And when you suspect an inflammatory or immune-mediated neurological condition, often the most key investigation is actually the imaging. So MRI and specifically would provide a lot more detail than other imaging like CTs. And it's often the first investigation that has the highest value early on. And there are certainly, although there are clinical similarities in presentation, there's certainly radiological distinguishing features that help us differentiate between these diagnoses. So starting with the optic nerve, for example, in multiple sclerosis, optic nerve lesion involvement is often quite small or focal, and short segments of the optic nerve are involved, whereas in MOGAD and in NMOSD, you can often have very longitudinally extensive involvement of the optic nerve, so often more than half of the length of the optic nerve can be involved. The patients with MOGAD, we demonstrated in an early study, that often have very anterior involvement of the visual pathway. So when you look at the back of the eye, even with an ophthalmoscope, you can often see disc swelling, and this is visible radiologically. And this is much less common in the other two conditions. So this is a characteristic feature of MOGAD. However, when you look at NMOSD, having the posterior part of the visual pathway, so where the two optic nerves connect up in the optic chiasm and then behind that, the optic tracts, they're more frequently involved in NMOSD and less frequently involved in the other conditions. So these are important clues that help us decide which diagnosis might be more likely. If we move on to the spinal cord, once again, there's a clear differentiator between multiple sclerosis and the antibody-associated conditions, NMOSD and MOGAD. So you usually have shorter segments of spinal cord involvement in MS. Whereas having what we call longitudinally extensive transverse myelitis, or LETM, where the cord involvement goes beyond 3 or more segments of the vertebra. So it's very long involvement of the spinal cord. That is kind of makes one think of NMOSD or MOGAD and makes one go away from a diagnosis of MS. So that's an important distinction. To make matters more confusing, MOGAD can also have short lesions like in multiple sclerosis, but the features of these lesions might be different. In MS, they can be a bit to the side of the spinal cord. They're called eccentric lesions. And then when you compare MOGAD and NMOSD, MOGAD often has very central involvement of the spinal cord where the gray matter of the spinal cord is involved. It can involve the lower part of the spinal cord or the conus, as I mentioned, whereas NMOSD can be very destructive. Both conditions can have quite a lot of swelling of the spinal cord, but NMOSD can cause this cavitation and this necrosis of the tissue that you don't usually see in MOGAD or MS. And then moving on lastly to the brain. In multiple sclerosis, there's a long history of research and tens of thousands of patients radiology studied, and there's often quite characteristic radiological patterns of where the lesions are. And this can be around the ventricles, just under the cortex or near the cortex, involving a part of the brain called the corpus callosum. There's some very characteristic patterns that you can see that make one think of multiple sclerosis. In contrast, in NMOSD, it can involve other parts of the brain around the ventricles and in the hypothalamus that are less commonly involved in multiple sclerosis. And MOGAD is interesting because in children, as Russell mentioned, it often presents as acute disseminated encephalomyelitis or ADEM, with lots of lesions involving the white and grey matter. In MOGAD, you can also have basal ganglia involvement, which is less common in the other two conditions. And brain lesions in adults can often be a bit big and fluffy and poorly demarcated borders that you don't really see in multiple sclerosis. And the last point is that MOGAD lesions can sometimes have association of the meningeal lining and the surface of the brain involved as well, which you don't see in the other conditions. The final point I'd like to make is that the radiology also differs over time. So patients with MOGAD, while they might have quite alarmingly large lesions at onset, often have quite a lot of resolution if they've been diagnosed and treated properly, and these lesions might go away or significantly shrink. And these patients in MOGAD and NMOSD tend not to have lesions when they're not having a clinical attack. So they don't develop what's called a clinically silent lesion. Whereas in multiple sclerosis, you can see patients who do not have clinical symptoms of a relapse still accumulating brain lesions.
Thank you, Associate Professor Ramanathan, for that thorough response. Radiological differences are particularly powerful and play a pivotal role in correctly diagnosing a patient with one of these disorders. Should a patient who has MOGAD, MS, or NMOSD be referred to a physician who specializes in all of these disorders, such as a neuroimmunologist, or can they see a local neurologist? Which one gives them the best possible chance of a good diagnosis and proper disease management? Professor Russell Dale, if you could please answer this question.
Thank you for that. I suppose the first question before that question is why does it matter? Discriminating between the three, we've discussed the fact that they look a little bit different clinically and radiologically, but we'll talk about this more in further questions. But now we know that the treatment pathway is different between all three of them. MS has its own treatment pathway, and the MS disease modifying therapies are completely distinct to NMOSD and MOGAD treatments. And even the treatments between MOG and NMOSD are probably a little bit different, even though they have in common they're an autoantibody disease. So I think whoever you see, whether it's a neuroimmunologist or a local neurologist, really the most important thing is that they know that these three disorders exist. In other words, CNS demyelination is not all the same. That is the single most important thing, that they realize there are autoantibody syndromes presenting with CNS demyelination. They consider them and they test for them if needed. So that is the single most important thing. And there are some extremely good general neurologists who are very good at acute neurology like this. The other answer to the question is, of course, different people around the world will have different access to different medical care. The ability to access a neuroimmunologist differs around the world. So, and likewise, there were some outstanding generalists who could do a very good job at this. The other thing is, you don't always have to see a neuroimmunologist, but it's good to have the advice of a neuroimmunologist sometimes, particularly in complex patients. And certainly in Australia, I advise my colleagues, and that seems to work quite well, that they manage them, but I sort of advise them if they ask for advice. So I suppose always it would be nice to see the absolute expert in your area. That's not always possible. I think as long as you've got someone who is open-minded and is willing to ask and read and learn, that is also extremely important and useful.
Thank you, Professor Russell Dale, for that excellent response. And that helps us transition perfectly into our next question. Why is it extremely important for a physician to get the diagnosis right on the first presentation? And what steps can they take in their evaluation, including the use of serum and cerebral spinal fluid testing, to increase the chance of an accurate diagnosis? Associate Professor Ramanathan.
Thank you. So I think the first part of that question, Russell largely answered in his preceding response, that these are conditions with different pathogenesis. They have different treatment pathways and they have different prognostic implications. So for example, in a condition like NMOSD, if you have made this diagnosis, this patient is likely to be on lifelong immunosuppression going forward. In conditions like MOGAD, when you're not yet aware of whether this patient has a monophasic or a relapsing version, you might be inclined to treat the monophasic episode in a particular way and then wait and see whether the patient has a relapse, or your treatment may change depending on the severity of the relapse or the first presentation. So this is a very important distinction, and it's been demonstrated that patients who were misdiagnosed as having multiple sclerosis and actually had NMOSD and MOGAD and went down an MS treatment pathway can have ongoing relapses, accumulating disability, and do worse. So making their diagnosis as early as possible is critical in order to guide the therapy and guide the prognosis of the patients. In terms of how best to reach an accurate diagnosis, I'd emphasize the point that for both MOG and NMOSD, the sample that would be ideal to test for the antibody detection is actually the serum. Cerebrospinal fluid can, of course, be tested as well, but this should be always in addition to serum and never in place of serum. And that's because the specificity and sensitivity for antibody detection is much higher in the serum. So if you suspect one of these conditions in a patient, then sending off a serum sample to a laboratory that can perform this test to the best of their ability with high specificity and sensitivity is critical. The other point that I'd like to make is that trying to get serum as close to possible as a disease onset. So if the patient presents and you suspect it, get a sample before, for example, empirical treatment might be started, before steroids or before plasma exchange or before rituximab or other things are considered. Trying to make sure you get an as early a possible serum sample will greatly increase the chance of antibody detection. Sometimes if you've had a remote event that was very likely to have been a MOGAD onset, and then the patient presents when they're in remission, say 12 months later, you might get a negative result, but it doesn't mean that patient's diagnosis wasn't MOGAD to begin with. So that would be my main takeaway.
Thank you, Associate Professor Ramanathan. We do agree that the right diagnosis is extremely important for the management of these patients. Although cell-based assays are present and pivotal for the diagnosis of MOGAD and NMOSD, is this the same case for MS patients or those who have a diagnosis of double seronegative NMOSD? Why or why not? Professor Fabienne Brilot, can you please answer this question?
Yeah, thank you. I mean, look, it's interesting because, of course, MOGAD and NMOSD were discovered part of an intense research that was done in the context of multiple sclerosis. So we had like this big bag of demyelinating diseases that everyone thought it was MS. And then along the years, we discriminated with antibody tests, NMOSD first and then MOGAD. So I think there's this tendency of us thinking that we should test for everything all the time. And it's not true. And I know we're going to talk about it a bit later. But the main issue that we have, of course, with MS and then seronegative NMOSD is they're negative. Now, we don't recommend to test all MS, but they're still not associated with an aquaporin-4 antibody or a MOG antibody. And that's an issue that we have, because when the test is positive, it's a lot easier because then you have your diagnosis. When the test is negative or it looks similar, but you can't find an answer, then we are in a situation that more investigations are needed. And that's why, you know, the clinical features, the radiological features that we discussed previously are very important. So at this time, after many, many years of research, we still do not have an autoantibody that is specific for MS. MS tend to be seen as a more T-cell driven type of disease. We think that the cell producing ultimately the antibody, which are called the B cells, are involved. And that's why, you know, you have many patients treated by anti-CD20 therapies in MS. They're depleting those cells that ultimately produce the antibody. So we know those cells are involved. There are some work that is done into finding some autoantibodies, but at this time, we haven't found it.
Oh, that's a great answer. You know, I guess I want to ask, and this is also for you, Professor Brilot. Should a physician order that MOG antibody or aquaporin 4 antibody test for every single suspected demyelinating event, or just the ones that they think are typical for the diseases?
Yeah, so I think, you know, it is an important question, because that's the core of the issue when we trying to discriminate by test all those diseases. And it's important to make a distinction between what we recommend and people in the field that are experts recommend and what is happening right now in the real world, because, you know, the research is always one step ahead of the generalization of the knowledge. So at this time, the reality, the real world is that we do test a lot for every demyelination events. And I'm saying that it is novel situations. We have people that are expert in the disease. You know, you have Darshi here and Russell here. They will be a lot more careful about what they send for testing. They will try to use those biological clues, clinical clues, to trying to define better the syndrome and then decide to test. But the reality is that, again, you have to, that decision is based on an expert knowledge at this time. And what we do see is a lot of first episode of demyelination between being tested. We do not recommend to do that. And the single reason why is no test is perfect. No test is perfect. In a perfect world, you could test everything, you'll have the right answer every time. But we are talking about biology here, and nothing is perfect. So in every time we test, we take a chance that we will have a false positive, so something that come as a positive, but it doesn't have the disease, or a false negative, which is a patient will have the disease, but then the test will come negative. So every time we test, we take that chance. If we test a lot for everything, that chance increases. So the error that is associated with the test, because the test is not perfect, even though it might be a very small percentage of every test we make, it's still multiplied if we test a lot. So that's why we do not recommend to test all demyelination for all those antibodies. It can sound very attractive, but the test is not perfect, and we will just multiply the risk of errors. We would prefer physicians, neurologists or neuroimmunologists to base the request of testing on radiological clues, clinical clues that will strengthen the chance of a true result and lessen the chance of a false result.
That's an excellent answer. I think, you know, that's one of the most confusing things to people. And I think this community question kind of, you know, this question will probably, and your answer to it will probably drive this point home. So this person asks, is a blood test the most definitive test for MOGAD and NMOSD because of the associated antibody? And what they're saying is an MS would therefore be harder to diagnose. So I think based on what you said, I'd like you to kind of answer, you know, speak to this question.
So at this time, in those new criteria that we have just published, to be MOGAD, patient need to have a positive test. And Darshi has highlighted the fact that the serum is the preferred samples. to do so. So MOGAD patients at this time are based on clinical features, radiological features, sometimes, you know, a balance between the two to strengthen the diagnosis, but they will be MOG antibody positive. When we do hit issues, is, as Darshi said, is when patients are treated for extended period of time with therapies that, for example, are killing the cells that are producing or will produce the antibodies. Therefore, the titers go down. The patient can appear seronegative. And then we have questions about, you know, when the patient is seen and when the serum is collected and tested, then we might have a negative result, which doesn't mean the patient was not positive to start with, but it's just being tested at a time where the antibody was very low in the serum. So testing is time dependent, as Darshi and Russell say. But it's very much also the diagnostic of those diseases should not solely be based on a test result.
Thank you, Professor Brilot, for your excellent responses. I want to talk a little bit about the frequency of getting a follow-up MRI when comparing these three disorders. Does the frequency of follow-up MRI vary between the three diagnoses? For example, how often should a patient who has MS get an MRI compared to a patient who has MOGAD or NMOSD? Associate Professor Ramanathan, can you please answer this question?
Yeah, thank you. That's an important question because I think the clinical practice is quite different for these conditions. So in multiple sclerosis, in a previous answer, I alluded to the fact that patients can have clinically silent lesions, so you can develop white matter lesions even without an obvious clinical relapse that brings the patient to come to medical attention. And so with multiple sclerosis or with any acute demyelinating event, I think best practice at first presentation is actually imaging of the entire neuraxis. So even if they develop optic neuritis, I think it's important that you get a proper MRI of the orbit and the brain, but you'd also look at the cord. And the reason for this is that you're trying to put together the whole picture and you need all the pieces of the puzzle to see what the baseline imaging is. So I think that's important for any of these three conditions at first presentation. Getting high quality imaging of the neuraxis where possible is important. With multiple sclerosis, we tend to repeat MRIs fairly at discrete intervals. So maybe in the first 12 months of disease, if they've just been diagnosed or just started on a treatment, this might be 6 monthly. Once somebody's quite stable on a particular immunomodulatory therapy, it might be an annual surveillance scan. And of course, if a patient has symptoms or presentation suggestive of a clinical relapse, then you'd be intending to do imaging more acutely then. So I think surveillance MRI is certainly something that we do undertake in best practice with multiple sclerosis. In contrast, the field of MOGAD is definitely much younger in this particular situation. But so far with NMOSD and MOGAD, you don't see as much the accumulation of clinically silent lesions. So when patients present with a clinical onset or a clinical relapse and imaging is done, there might be new lesions. But looking at studies that have followed interval imaging when a patient's been clinically in remission, the incidence of new lesions that were not clinically obvious are much lower. And in one study demonstrated to be immediately preceding a relapse. It was just coincidental that the scans were done at that point in time. So I think from a clinical and practical perspective and a health economics perspective, repeating MRIs in patients with NMOSD and MOGAD on a very regular basis is probably not evidence-based and not called for. But certainly from a research perspective, to try and understand longitudinal evolution of, brain volume and atrophy and what happens to some of the lesions over time. Because these are newer conditions that are under intense scrutiny, imaging does get done more frequently. But from a clinical perspective, that regular surveillance MRI when a patient's in clinical remission is not occurring in MOGAD and NMOSD the way it does in MS.
Okay, thank you for that. So in talking about, criterias and things like that, I just want to, I guess from all of us, we want to congratulate you and to those involved in this first MOGAD international proposed diagnostic criteria. We're really excited about that. So how does this criteria help both patients and physicians all over the world? It's a huge hot topic right now. I want to hear from Professor Brilot and Associate Professor Ramanathan.
Thank you. Look, these criteria, this paper represents a huge amount of work. Many discussions, and we're very proud of that work. I do think it's important to have those criteria out, so there is an advice that is out there. And as I say, research is always one step ahead of what the community and the general neurologists are looking at. So I think that having those criteria published is very important. I think those criteria are very pragmatic in a way that we know that the clinical features, the clinical presentation, the radiology is important, and we know the test is important. And I think they are trying to mix and combine all those aspects to make sure that the diagnosis is as informed as possible. For example, in terms of the testing, I think it's a quite of a fair and honest presentation of the testing. As I say, no test is perfect, and I think this work is also including that aspect. It doesn't try to look like the testing is perfect. It doesn't try to present the diagnosis of MOGAD as an easy thing to do. I think it would present a fair view of the difficulties that neurologists or physicians might have diagnosing and discriminating between MS and MOSD and MOGAD.
Associate Professor Ramanathan, you have any comments?
Yeah, I think the recap of the diagnostic criteria is that you need three things in order to make this diagnosis. You need a core clinical criteria. So does this patient have optic neuritis or transverse myelitis or cortical encephalitis or ADEM, etc.? And then is this patient, secondly, having a positive antibody result? And thirdly, is there an exclusion of a better diagnosis? And I think the important feature that the diagnostic criteria provide is that they stratify the antibody result. So if this is a very high positive result determined by some guidelines that are documented in this publication, then you can make the diagnosis with the criteria and a good, robust antibody test showing a clear positive result when you have excluded another diagnosis. However, one helpful feature that the diagnostic criteria provide is that if the antibody result is not done using the optimal gold standard live cell-based assay, or if the titers are very low or it's a low positive, they recommend that in order to make the diagnosis, you have to look to some clinical or radiological supportive criteria. And I think this speaks to the point of when you should and when you shouldn't test for MOG antibodies. And I suppose the main thing that would be useful is that in patients who have a very low positive result, if the diagnostic criteria can help clinicians who are looking after these patients rethink the diagnosis or alert clinicians regarding the stringency of what type of test they've got an answer with, and what the levels are, and whether or not this actually fits the picture from a clinical and radiological perspective. Because I suppose the single biggest concern among many international experts is that when commercial assays are used where titers may or may not be provided using fixed assays rather than live assays, you're going to get a big cluster of low positive patients who may actually have multiple sclerosis. And as we discussed earlier, this has therapeutic implications. So being able to use the criteria, which I'd also point out had a very nice red flag section to find out when things don't fit the bill and when you should look further, or when this person actually might just have garden variety multiple sclerosis and should be treated as such, is quite an important distinction to make. I think there are some limitations with the criteria in that they, at the moment, operate on a, with the assumption that everyone has access to these investigations and these tests. And this is not necessarily the case on a global field. And as our research expands our understanding of the clinical phenotypes and what represents a longitudinal follow-up of MOGAD patients, these criteria may undergo revisions as it has in multiple sclerosis and NMOSD.
Thank you very much. I think that we have a community question here, and we have several actually. We're trying to get to some of them, but the person asks, assuming a MOG positive person has seizures as a first-time attack, which is successfully treated with steroids and put on Keppra, how long should they continue Keppra, assuming no further seizures and the likelihood that they were caused by MOG? Should this time period be shorter than someone who had seizures that have stopped for some other condition? And I want to ask Professor Russell Dale this.
Yeah, that's a good question. I think always with any medical problem, you treat the cause, because at the end of the day, Keppra or any other anti-epileptic is just treating a symptom. So obviously steroids or any other immune treatment are the treatment of the underlying cause of the problem. As for the how long should you stay on the anti-epileptic, I don't think there's any different approach in this context to any other context. And generally, it's the practice of most pediatric neurologists to continue the anti-epileptics for about 12 months after there has been a brain problem causing seizures. So I really don't think there would be any difference. That would be my practice. I would usually keep the Keppra going for around 12 months and then try to stop it. Obviously, if there were ongoing seizures, you would continue it or change the medication.
Thank you, Professor Russell Dale, for that excellent response. So this next question has sparked a lot of curiosity in the MOGAD community, and it is quite important. Does the international MOGAD diagnostic criteria affect the previous MOGAD diagnosis given to a patient? For example, are physicians going back to the MOGAD diagnosis of every patient and confirming that they have MOGAD based on the proposed international diagnostic criteria that has just been released? This is an extremely hot topic. Associate Professor Ramanathan, if you would like to answer this question.
Thank you, Jenny. I think it's important to understand that the diagnostic criteria are tools to try and assist with clinical diagnosis and practice, and not, not a very prescriptive, definitive answer to questions. So I think these are tools that should be used in context and in the clinical context of patients' other paraclinical investigations and clinical findings. So I think in a person who's got a phenotype that's very consistent with MOGAD, who had a MOG antibody positive result, who responded to treatment the way you'd expect, and who's being managed in a way that seems to be working for them, I don't think there is any requirement for clinicians to go back through all their MOGAD patients and determine whether or not the diagnosis was correct or incorrect. I think where the criteria really come into play is when you have these atypical patients who may have had an antibody result, like I mentioned earlier, that may or may not have fit with the clinical picture of MOGAD, and you want to try and identify whether you were on the right track or not. And I think these criteria might help provide a little bit of direction from that perspective. In general, when, as Fabienne and Russell have mentioned earlier, pediatric demyelination is quite different in children under the age of 10 compared to adult demyelination. So in a child who presents with demyelination, I think it's fairly accepted that all of these children would be tested for MOG antibodies, whereas in adults and adolescents presenting with demyelination, we'd require specific features to make us suspect MOG antibodies in order to test for it appropriately. So I think the diagnostic criteria provide more of a guideline for these atypical cases that haven't responded the way you thought they should, or haven't looked like MOGAD properly in the beginning, to look for other reasons.
Thank you very much. We kind of want to move on to talk about some treatments. Can you talk to us a little bit about the different types of effective treatment options for these three disorders? Associate Professor Ramanathan?
Sure. So all three conditions are demyelinating conditions, albeit with an underlying differences in their pathogenesis and the disease mechanism. So I think in terms of acute treatments, I would say steroids kind of cure all ills in neuroimmunology. It's not necessarily the safest or most appropriate long-term treatment, but you often see rapid responses to pulse steroids or high-dose oral steroids, for example. And this is certainly the case with MOG antibodies and NMOSD, with MOGAD and NMOSD. In multiple sclerosis, it has been demonstrated that steroids might reduce the severity and speed up the recovery from an initial episode, but long-term steroid use in MS hasn't been demonstrated to have an underlying disease-modifying approach. In MOGAD, this is ongoing work and the topic of much interest about how steroid treatment in the first year might reduce early relapses. And then in terms of other early treatment, definitely in NMOSD and to a lesser degree in MOGAD, plasmapheresis has been identified as being a fairly effective early treatment, particularly in quite clinically severe cases. When you want to talk about maintenance immunotherapy, it then depends on the underlying condition. And as we discussed before, the treatments for MS vary from the treatments for MOGAD and NMOSD. And in MS, you have some of the older treatments, which I suppose for we could classify as maybe a slightly low efficacy treatment or low to moderate efficacy treatment, which served most MS patients for many decades reasonably well. And these include injectable treatments like interferon and glatiramer acetate. And this has been around for many decades and reduces relapse rates by about 30 to 40%. And then you've had more moderate efficacy treatments that reduce relapse rates by 50 to 70%. Oral treatments, including fingolimod, dimethyl fumarate, cladribine. And these have been very welcome to the MS community, where they don't have to inject multiple times a week, for example. And then you've got the very high efficacy treatments that reduce relapse rates by 80 to 90%. These include infusion therapies generally, such as monthly natalizumab or 6-monthly ocrelizumab or annual alemtuzumab. And these have really changed the face of severe multiple sclerosis and made patients who've got very severe disease able to live a relatively normal life. This has been a massive advance in the field over the last 15 years or so. Now, when it comes to NMOSD or MOGAD, maintenance therapy is interesting. Maintenance steroids certainly works very, very well, but the systemic and the metabolic and the cardiovascular side effects of long-term steroids and bone health make it not a viable option in the long term. Oral immunosuppression, so steroid-sparing agents like mycophenolate and azathioprine have certainly been used with variable success. There's a lot of interest in the use of maintenance intravenous immunoglobulin, which seems to show efficacy, but there's limited a bit by cost, immense cost, and also availability globally as an ongoing treatment is something to think about. And then we have the B-cell depleting infusion therapies like rituximab, and this has certainly proven to be very effective in conditions like NMOSD, perhaps slightly less effective in MOGAD. And then for patients who are quite refractory to a number of these conditions, some of the IL-6 targeting monoclonal antibody infusions such as tocilizumab or satralizumab are being trialed and in use for some of these relapsing patients. So there are a number of maintenance immunotherapy options, but these differ in MS compared to NMOSD and MOGAD.
Well, that's a great answer. And I got to say, I'd like to hear a follow-up from Professor Dale, just about whether these treatment options are going to be the same for the pediatric patients.
Well, the good news is that Darshi's answer sort of applies to children. I suppose always adolescents are worth an extra mention, of course, because no adolescent wants to have a medical problem, and they certainly don't want to take any medicine. And so compliance is a classic challenge. And people would like to think that taking a pill is more likely to be compliant than injecting, and actually that isn't necessarily true. So essentially, the treatments are similar to what Darshi described. We now have first level evidence that fingolimod and nitalizumab are effective in adolescents with multiple sclerosis. And the treatment of the antibody-associated diseases like NMO and MOG is similar to as Darshi described. I think the main principle is for aquaporin 4 disease, so NMOSD, you really need to start chronic immune suppression as soon as you make the diagnosis. And it needs to be either rituximab or a similar B-cell drug or some other potent immune suppressant such as mycophenolate. With MOG disease, I think it's a little more, a little less clear what are the best ongoing treatments. Is it low-dose steroid, which I certainly believe is effective but potentially problematic? Intravenous immunoglobulin is also very favorable in kids, or could it be rituximab or mycophenolate? I think that we need more data to really advise what is the best treatment. And for patients who don't respond, I think it is useful to have the option of the IL-6 therapies beyond that. And as we know, there's a clinical trial ongoing in those patients with MOG disease who are relapsing.
Thank you, Professor Russell Dale and Associate Professor Ramanathan. What if the diagnosis is questionable between MS and MOGAD? What would be the preferred treatment for those patients? Associate Professor Ramanathan.
It's a difficult question. I think you've basically got to make a bet generally on one or the other, and you've also got to keep an open mind. And I think it's okay to say that some patients are complex and a bit grey, and you want to wait and reevaluate with imaging and see how they're going from a clinical perspective. It's better to hold off on making a diagnosis than jumping into a diagnosis that may or may not be correct. And I think their response to therapy can be quite telling in some patients. So empirical response to treatment can be quite helpful. The obvious agent of all the ones I described that works in both are B-cell depleters. Multiple sclerosis, ocrelizumab, rituximab works, MOGAD, rituximab probably works. But I would caution that that is a fairly significant treatment choice. And I think it depends a little bit on disease severity. So if you're not entirely sure and the patient has a significant myelitis or a significant brain involvement, then that's a treatment that I would be fairly comfortable escalating to. However, if a patient has a very mild optic neuritis, I don't think I'd be entirely comfortable escalating to a treatment that causes B-cell depletion with the, inherent infection risks and issues with responding to vaccinations that we've all experienced in the last few years. So I think trying to come to the right diagnosis, even if it takes a little bit of time and a little bit of watching and waiting and seeing the natural history or response to empirical therapy without jumping into a diagnosis is reasonable. And I think if disease severity is enough, you could use an agent that could potentially work for both.
Thank you, Associate Professor Ramanathan, for that excellent response. So we know that MOGAD patients tend to be a little bit more steroid responsive compared to MS and NMOSD patients. Can you talk to us a little bit about that, Professor Russell-Dale?
Yeah, thank you. It's an interesting topic, and it's a bit of a hot topic, and there's disagreement in the community about this. I think what we clearly know that is in MS, it is okay to treat with acute steroids for 3 days, pulse steroids, but really you wouldn't use steroids otherwise in the context of MS. I don't think that is so true with MOG disease, and it's also partly true with aquaporin 4 disease, NMOSD. And it's simply a fact that there are some patients that seem to be in remission with low doses of steroids. Even some aquaporin 4 patients who are on immune suppressants sometimes need a bit of prednisolone. And I think we need to be a little bit open-minded about this in the community, that there are some patients who can be preserved and avoid having a relapse on relatively low doses of steroids, such as 10 milligrams a day. The reason it's important is if there were some very risky periods in clinical course, and about 2 to 3 months after a first event is a high-risk point of an early relapse, there are some patients who may get an optic neuritis and be left with a visual deficit. So if we can reduce the chance of that happening, we should really think about it carefully. And I think there is fairly good evidence that low doses of steroids can get some people through that tricky and vulnerable period with MOG disease. So I think we need more data. I think more data will come to help us understand that risky period and whether steroids or other agents are superior.
Well, thanks for that. I think that's a fantastic answer. I'm going to ask you another question, Professor Dale. It concerns clinical trials. Do you think it's essential that only relapsing MOGAD patients are enrolled in the clinical trials and these preventive treatment studies to bridge the gap in identifying what is effective for the MOGAD community and stop skewed data arising from many monophasic patients that are in these studies? What are your thoughts?
It's interesting. I think if you asked me that question now, I would have answered it differently about 12 months ago. I'd have probably said probably yes, but now I'm not so convinced. Partly for 2 reasons. One, I think there is emerging data to tell us that actually relapsing disease is probably more common than we thought. I think we used to quote for children, it's 25, 30%, and for adults, maybe 45, 50%. I think those are rising for both children and adults. So the risk of relapses is probably higher than we thought a few years ago. So that does change the landscape. But then secondly, I still think there are opportunities in the monophasic patient. So a patient who's had a single episode, a first episode, we probably have an opportunity there to reduce the chance of an early relapse. And so I think we do need clinical trials in that area, actually. I don't think it is just the relapsing patients. I really think the first episode patients we need to look at carefully and think, is there any way we can reduce this patient from having a further event? And in an ideal world, can we turn a potentially relapsing patient into a monophasic patient? Because there's absolutely no doubt that the more events you have, the more likely you will accrue disability either to the optic nerve, to spinal cord, or to the brain.
Thank you, Professor Russell-Dale, for that very important response. I would like to move on to the future of your research and in MOG antibody disease. So we know that the future is looking bright for MOG antibody disease with the acceleration of research and treatment happening at this current time. What exciting research is being done for MOGAD that you are working on? We are excited to hear from every single one of you. Professor Brilot, if you would like to start us off, and then Associate Professor Ramanathan, followed by Professor Russell-Dale.
Yeah, thank you. Well, I mean, as you just heard from Russell and Darshi, at this time, there's actually no predictor of whether a patient is going to relapse or not. There's we think the antibodies stay high, maybe longer in relapsing patients. But again, we know that after they relapse, and we just classify them as relapsing patients. So predicting whether a patient is going to be a relapsing patient is something that is important, because it can help to manage better the treatment of those patients. It could also help, to include them in clinical trials and segregating them, the different groups better, to answer better questions. So, and that's what we're working on. We basically would like to predict whether a patient is going to be a relapsing patient. And we do that as neuroimmunologists, of course.
I guess from my perspective, I'm quite interested in identifying things that could expedite diagnosis. So I think global access to some of these gold standard diagnostic tests is difficult. And I think that the cost is prohibitive, and you can't expect people from all regions of the world to send away to labs that perform these tests. And I think it makes a very real difference on the ground for a patient to have the right diagnosis and go down the right treatment path. So I think trying to identify clinical radiological predictors of diagnosis at disease onset is something that I'm very interested in. I also think that looking at longitudinal radiological biomarkers that may help with prognosis in some of these patients. Some of the children have ADEM. Do they go back to normal from a cognitive perspective completely? Do they have neurodevelopmental problems? For the adults, a lot of the patients who have optic neuritis are significantly impaired. Are there markers on radiology that may help us identify that this person is more likely to have a more severe disease course? And similar to what Fabienne said, what can we identify at onset that can help modify management to give these patients the best outcome? And then I suppose the last thing is I do think it's completely critical to have clinical trials at disease onset and at relapse that help identify the best way to induce remission in MOGAD.
I'll just sort of add to what Darshi said. I mean, I echo what Fabienne and Darshi said, obviously, and I will obviously do what they tell me to do. No, but that's only a joke. I actually think the outcomes are really, really important. And as Darshi just touched on, ADHD is probably much more common as an outcome of kids who have ADEM. In the past, the fact that they were on intensive care and now they're walking around and happy and back to school is great. And so we call that a complete recovery. But in fact, certainly in my experience, quite a few of the children have taken a slight hit and do have some executive problems or ADHD. So I think that is an area we need to look into, full recovery. Likewise, the optic nerve doesn't always fully recover, even though you may have good visual recovery. So I think there is a lot of that stuff that we need to look into more. But as Darshi said, I think we need better level evidence about how to treat patients. That is probably the single most important thing. Can that be done in single centers? No. Can it be done with multiple centers in countries? Yes. Or internationally? I think there are some really key questions about how we treat after a first event, but also relapsing disease. Good news is some of these trials are started, but I think we need much better evidence.
We are definitely excited to see all of this research in action. So we would like to say a huge thank you to our wonderful Australian experts, Associate Professor Darshi Ramanathan, Professor Russell Dale, and Professor Fabienne Brilot, who have taken the time to be with us today and explain thoroughly the overlaps and differences between MOGAD, MS, and NMOSD. We continue to follow your incredible research closely and the outstanding impact it has on both the MOGAD community and physicians all over the world. We look forward to seeing the international MOGAD diagnostic criteria in action as we continue to follow it as it further develops.
You're on mute.
Done that more than once. Thank you. I just wanted to say we call you guys the Australian Dream Team. So maybe it was good that I was on mute. So any of these unanswered questions will be collected. We're going to answer them, have the doctors answer them, and make them available in a follow-up MOG blog for the event. The MOGcast is going to be available on our YouTube channel as well. So I just want to thank you guys for coming. I mean, this is always a great discussion. It's the second one we've had, and we really, really wish that we had so much more time because there's so many questions coming in. So thanks for that great discussion, and I hope you guys have a good rest of your day, and everybody else who's here in the US on this side of the world has a good rest of their evening. Take care, everybody, and thanks.
Thank you for having us.
Later, guys.
See you.
See you.